2005, the New York Times and Congress and the CMS came out to New York State and said, this is a disaster area. Right? We have a Medicaid program that's out of control. We need to do something about it. And as we'll see in a moment, often in that situation, there's a search for villains. Right? That's the focus. We're going to talk, though, today a little bit more about what kind of things we're trying to do for the next phase. Not just looking for bad guys, but thinking about how the program is designed and what people do within it and what kind of information they receive. So I'll start off with a couple disclaimers. I steal my ideas from many different locations, and so if you see good ideas in here, they probably came from somewhere else. I like things a compliment to adopt people's ideas and not plagiarism. If you see slides here that you like, please feel free to use them. No attribution necessary. And you can call me or email me and ask for a copy. And if you know any whistleblowers who want to talk to the Inspector General personally, 518-473-3782, ask for Jim. If we look at Medicaid in New York State, right, and Medicaid generally, what we see is a situation where we have $350 billion that is spent on the Medicaid program nationally, both state and federal expenditures. And there are 50 million enrollees, which means 1 in every 6 Americans is already in the Medicaid program. If you look at the examples from Australia, Ireland, and other places, that kind of basic safety net program is usually the basis to expand and to make sure that everyone in the country has medical care. The key to understand about New York is we're the largest state program. The second biggest is California with $33 billion, even substantially less expenditure, even though there's substantially more people in the program. Here's the next thing, though, about New York. We have the best integrated data systems of any healthcare program in the country, which is pretty amazing when you think about it. Right? Like, go see my friends in New Jersey. They have not put in a new data system in 20 years in New Jersey Medicaid. They have difficulty figuring out what they're spending money on and how they're spending it. If you go to CMS, that runs the Medicare program, they have one system for hospitals, one system for physicians, one system around managed care, one system for prescription drugs. 4 separate systems, and then they have a few others that are up by the side, like durable medical equipment. These systems have a great deal of difficulty talking to each other. They're built at different times for different purposes. In New York State, we can tell where a patient went to a clinic, where they went to a hospital, what diagnoses they had at each stage, and what drugs they were prescribed at each of those locations, except for the hospital. The second thing to understand about the data is that the reforms that have happened in the last 2 years under Governor Spitzer and Governor Patterson have made the information that much more accessible. The APG system, which is up and running, we hope, as we speak, right, starting these first 6 months of 2009, gives us diagnoses and services across the board for a variety of patient conditions. So what we're working toward is a complete picture of the patient. I'm going to show you why this is critical for program integrity and how we intend to use this information. Now, why you hear the term data mining? You've been hearing it for 20 years. All right. What I want to convince you of today is how much difference data mining makes in the way the program is run and the way the program integrity part of it in particular is focused on. So we want to use data mining not just to find bad guys. We want to use data mining to look at the best outcomes from the data that's available to us, right? We want to identify and communicate adverse events. So if we have risks of adverse events, we want to be able to tell people before something bad happens that it's out there. We want to give to compliance officers who work in every large healthcare facility in New York what we're seeing. What kind of risks do you face in your organization? How can we tell you to look for them? We want to train and equip our own employees at OMIG to look for these data patterns. And one of the things that you see out there happening is that the view that someday everybody's going to be a data miner. So in South Carolina, what they do is they put all the Medicaid data for providers up on the web. So you can see every physician in the South Carolina system, how much money they got, how many patients they saw, what the average cost per visit was, and so forth. Now, we're not going to do that anytime soon in New York, but it gives you an idea of what some of the models are to say not just state employees should do this work, we should look for contractors, and then we should look for everyone in their spare time to go play with the data. The other thing is from the federal side, what's happening is that the federal government is hiring a myriad of contractors. And this amazes me. If you ran the world's probably most expensive healthcare program, wouldn't you try to integrate all the data in one place? What the feds have done in the last 5 years is to break it out into separate contracts for specific providers. So you'll see the acronyms, ZPICS, RACS, MICS, and CMS all have data in separate boxes, and they try to compare with each other. The other thing that's happening that we are very much conscious of is that it's not just us, and it's not just people in their spare time. Whistleblowers today are buying the data from CMS and other places and doing a run on it to see if the allegations that a whistleblower comes forward with, the lawyer tests it to make sure it's accurate. So all these people are engaged in data mining of the Medicaid and Medicare data. Here's the next piece. Again, in 2005, when the New York Times ran its series, it talked about bad guys doing bad things. There was a bad dentist, there was a transportation provider that was tied into a daycare center, and the picture is we're losing money in this program because of all the thieves. Now, in every human situation, there are people who take advantage of it. But I want to suggest to you today that the much greater loss is not the outright intentional conduct, right, by people trying to defraud the system. But much greater loss is from the idea of abuse. Now, when I was a prosecutor, we thought of abuse as beating up patients, right? It wasn't fraud, it wasn't taking money, but it was doing bad things. But in fact, if you look at the definition in the law for abuse, it's much, much broader than that, all right? Abuse means practices that are inconsistent with sound medical or professional practice, which result in unnecessary cost, and payment for services not medically necessary, and services which fail to meet recognized standards of health care. All right? And I've talked to some of my colleagues in the Department of Health, and I said, if you define abuse that way, as defined in this regulation, that was Department of Health regulation until we took it over, that pretty much covers the waterfront. You're going to have every malpractice case as a Medicaid Inspector General case. And the answer is no, we're not going to do that. A, because we couldn't, and B, because we want to focus on patterns. We want to focus on practices that replicate themselves over and over. We want to disaggregate the data that we see and figure out where the outliers are. Now, Atul Gawande did a wonderful piece in the New Yorker last week. And what he did was run the Medicare data, right? Another freelance data miner, run the Medicare data. What's the most expensive place in the country for Medicare? And it turns out that Miami is first, but Miami's been done. So he decided to go to McAllen, Texas. And McAllen is down on the border with Mexico. It's a very poor area, except for the physicians. All right? The physicians in McAllen do very well. Medicare spends $3,000 a year more per Medicare beneficiary for health care than the average person in McAllen makes. All right? And what he wanted to do was to find out two things. One, why is this? And the second one was, have people thought about this in the community, and what have they done about it? And the short answer on the second one was no one had ever thought of it. And on the first one, no one had really considered why their costs were higher, knew that their costs were higher, and were able to articulate a reason or a result. No data showed that McAllen did better. In fact, a lot of it showed that McAllen did worse, and Miami the same situation. Dr. Gawande then went on to look at why are we spending the money. As it turns out, direct billing by physicians in New York State is under 2% of our total expenditures. Then we pay for clinics and other things. But the most expensive piece of medical equipment was the physician ordering pad, right, and the pen, because far more than what the doctors actually provided was what they ordered. And he's looking at the data. In Albany, the Medicare spending average is about $5,000 per enrollee. Well, actually in Miami, it's now $14,000 per enrollee, and McAllen is down around under 14. So what you see is and he attributes that almost entirely to differences in ordering patterns by physicians. And the Dartmouth Atlas is the citation that I use for that, because it gives you, it's a wonderful series of maps that shows you for all kinds of medical procedures exactly what the dollar levels are and what the volume of services is. Now here's the other thing that was strange from Gawande's analysis, both from the literature and his personal observation. It turns out that the high-intensity areas, the areas that have greater services paid for by the Medicare program, actually also have more unhappy physicians and poorer quality outcomes in even correcting for the things that you would think, obesity and diabetes and cardiovascular issues. The patients were less happy, the doctors were less happy, the services were greater, and the outcomes were worse. And so obviously there's a lot of room for us to focus our efforts on identifying what I'll call abuse, right? Services that are not consistent with medical standards and cost more and get worse results. So then we say, let's figure out, at OMIG, let's figure out what services we can focus on, which we're not going to have a fight about what's professionally appropriate. All right? So if I go to a physician's office and I say, I'm a lawyer and I'm going to tell you how many office visits you need for your patient with back pain, all right? They're going to throw me out because who am I? I don't, where's my degree? Where did I train? So then we say, what are the areas where we have the most data points and the areas that we have the clearest guidance on what's appropriate activity? And as it turns out, drug therapy is about as good as it gets, because for every prescription drug transaction, there are 5 points of information that we can, actually there are 37, but there are 5 that we can focus on. We have a unique patient, we have a unique prescriber, we have a unique pharmacist and pharmacy, we have an NDC code that tells us exactly what the drug was, and in many cases we have, there's a 5th one which I can't think of at the moment, but I'll get to it. And but here's the key, all right? Now we have 5 points. Now in an office visit for a physician, what points do we have? We have a unique patient, but we really don't know in a lot of clinics which physician provided the services, right? We don't know what exactly the services are, right? It says intermediate office visit. That can mean an awful lot of different things in different places. So with those 5 points of data, we now have a lot of things that we could do. What do we know also about drug therapy, all right? Appropriate patient selection for a given drug, all right? There are a series of counterindications for patients for certain kinds of drugs. If you have inconsistent therapies from 2 different sources, if you have, you're not age appropriate for certain kinds of drugs. Appropriate prescribing. Who's the person doing the prescribing? And how do they make the decision about what dosage to provide, what instructions to give, and so forth. Appropriate monitoring of the patient after the drug is prescribed for both intended effects, is the drug working, and for side effects. The adverse events that occur in the population, to what extent are we seeing them in this patient? And the difficulty is, in addition to having 5 data points, it also requires knowledge and collaboration and communication among patients, physicians, and pharmacists. What do we know about adverse events? Well, as it turns out, patients do not report more than 25% of adverse events to their doctors. And my last job, we ran a focus group to say, why is this? Why don't patients tell their doctors that they're having adverse events, they're having side effects from a drug? Well, they didn't want to upset the doctor. The doctor made a decision about what disease condition they had, what would work, and they figured the doctor knew better, and they didn't want to upset him by questioning his judgment. All right? A classic kind of discussion. Then we ran discussions with internists and said, tell us about how you select drugs and what you do, what you do once you select them. Well, when we looked at specialists, they had a small list, but for internists, they have a much larger list, and they rely upon information from their patients, information from the detailer, and there's a hierarchy, and you got pretty far down before you started reading the FDA insert. So now we know they have to collaborate, and you're going to have data from a variety of points. All right? So then we say, okay, how do we go about finding out the information we need to figure out how drugs should be prescribed and whether they're being prescribed appropriately and whether we have adverse events as a result? So we go back to the federal agencies who have responsibility for safety issues. All right? We can tell to the single digit how many deaths in this country, how many deaths there were in this country from auto accidents. Right? It's 42,000 and change last year. U.S. deaths by homicide, we can tell within a couple of digits, 18,500, because the CDC tracks that information. Air crashes, I can tell you there were 71 people killed in commercial U.S. air crashes in 2009, right? Because I can go to the FAA and get that data. How many people were killed by adverse drug events or significantly injured? And the answer is nobody knows. Right? Nobody knows the answer to that question. And in 2006, as we'll see a little bit later, The National Institute of Medicine did a report on drug safety and promoting and protecting the health of the public in the drug context. And they basically said, FDA, you've fallen down on the job. It's not your fault, you don't have enough resources to do it, and most of what you do is because you get a fee from the pharmaceutical companies. We need you to think more about what happens to these drugs once they get out on the market, right? When drugs are reviewed before approval, narrow population, specific therapeutic issue, does the drug work, and does it kill those people between 20 and 35 who took it during the study, who were screened out at prior conditions? All right? Not a great map, and so what you find out is once you take that drug from 6,000 study subjects to 3 million users on the street, all kinds of stuff starts showing up in the data if you look at it, but the FDA had no money to look at it. Here's the second problem with the FDA. Several years ago, I went to the FDA. We had gotten a whistleblower case, and it alleged that a particular manufacturer of the surgery devices that, help me here. No, not stent. It's doing it remotely through a TV screen and. No, boy, this is... Anyway, in the old days, you used to cut people open to sort of chest to down here, and today you do it through laparoscopic surgery. Thank you. Okay. That's the brain freeze when you're a speaker. So we went, and there are devices that were being used, and you're supposed to push this device through the outer skin, and then you're not supposed to perforate the bowel, which is on the far side, which is part of the deal here. And we found there were literally hundreds of bowel perforations by surgeons using this device. And we did a little research and said, why is this happening? A, they should report it to the FDA, because it's a problem, it's an adverse event. But then we said, why does this happen? Why are the surgeons, everybody knows you shouldn't do this, why are they perforating the bowel when they push down on this particular device? And the answer was, as it turns out, people who become surgeons are very good at dealing with the visual field in front of them, right? This is surgeons from the 80s and 70s and 60s and 50s. So they would look at the visual field. They could see all the organs right down there. They had their scalpel. They knew where to push things aside and retract and so forth. Some percentage of those people were not good at translating from the video screen to the reality inside the patients. And so we said, FDA, you've got to do something about this because you're going to kill hundreds of patients. They're going to kill hundreds of patients, not because they're bad people, but because they just don't have that brain capability of seeing things remotely and using tools. And the FDA said to us, well, that's not a product defect. I said, what do you mean it's not a product defect? It's killing people. They said, we define a product defect as, and they walked through the regulation. And I said, well, what about these doctors who can't use it? Who just don't physically have the ability to use it. And they say, well, we're not in the business of regulating physicians. We're in the business of regulating manufacturers. Well, that's great. About 7 years after that conversation, they did establish a group to think about these issues, the interface between the physician and the device. But we have the same problem in drugs. Right? We have the same problem in drugs, except if you perforate a bowel, you know about it within a relatively short period of time. If you screw up on your prescribing activity, you may never know, because there's all kinds of reasons why it wouldn't happen. So the issue is, if we look at the use of drugs, the Institute for Safe Medication Practices, which is one of my favorite organizations anywhere, they make state employees look like people interested in malice and lucre by comparison, just very earnest, sincere people. And what they say in their most recent report, there's a lot of people, nobody knows how many. And I've looked for studies on this issue. Of course, there's no funding for studies to say how many people get killed by drugs. There's not a lot of drug companies that want to underwrite that research, and not a lot of universities that want to do it because when they go for the next grant, they're not going to be very popular people in the game. So what happens is that we have a lot of difficulty finding out how bad things are. So 2006, the Institute of Medicine comes out with a study, and what they say is, this is the best estimate based upon a review of the literature. 400,000 preventable drug-related injuries occur each year just in hospitals. All right? Another 800,000 occur in long-term care settings, and 530,000 occur in ambulatory patients and outpatient clinics, just for Medicare. Okay? And they said, these are the numbers from the literature, but they're probably underestimates. So we have a huge problem. And it's not, we traditionally think of drug problems as cost issues, right? Do patients have access to drugs? How much do drugs cost? We're spending X. Some of the studies suggest that the adverse events from drugs are more expensive than the drugs themselves. So that is a huge hit on the system, which has no benefit to anybody and significant harm. So we say, let's go back. Remember those doctors that FDA doesn't regulate? If they want to do it sound medical and professional practice with respect to drugs, how are they going to do it? Right? Let's assume I'm that good physician in my study, and I want to make sure that I'm doing my job with respect to adverse events and deciding what drugs to use and what dosages to use. Here are the things that I have available for me, right, from the FDA. The first one is labeling, right? So if I get an advertisement from a drug company, you can read the labeling and see the contraindications. I can use from the FDA black box warnings. There are several hundred black box warnings that are current. Now, if I'm in a subspecialty of cardiology, that's not too hard to do, right? Because they only use a dozen drugs or 24 drugs on a regular basis. But I'm in internal medicine, I may use hundreds of drugs in my practice. So how do I figure out which ones they are? Well, here's what I can do. I can go to the FDA list, and each drug, I can click on it, and I can pull down the black box warnings for that drug if I can navigate the website to get there. All right. Now, let's be fair. You're a physician in private practice. You're seeing a patient every 15 minutes. What is the likelihood that you're going to be able to do that? Pretty slim. Here's the next piece. Manufacture Dear Doctor letters or Dear Health Care Professional letters. And again, these letters go out to doctors who are known to be prescribers of a particular drug, and they come in the mail with 1,000 other things in a doctor's office. And the hope is that in his spare time or her spare time between fighting with insurance companies, that they're going to read this Dear Doctor letter that talks about a specific drug that they may not prescribe on a regular basis. The FDA MedWatch, all right? Well, the FDA MedWatch gives you adverse event reporting, but it's engrossed, we'll talk about that. Literature review. You can sit in your office and you can read medical journals as they come out. But think how hard it's one thing to read medical journals, and this, when there were relatively few, it was a little bit easier. Today, that's almost impossible. There are online journals. There are journals you have to take with a lot of salt because they're really supplements put out by drug companies. That process itself is very difficult. And you figure the average patient walks out of their 15-minute physician visit with what, 1 or 2 prescriptions? Some of them walk out with 4 or 5. What kind of research do we expect the physician to do in each of those stages? And here's the trouble. The FDA really maintains no system which will assure that physicians and pharmacists and patients, because remember we have 3 different players in this process, can access this information reliably and consistently. All right? So the FDA has fallen down on the job. That's the reality. All right? Back to our black box warnings, right? There's a regulation that says what they have to. Special problem, particularly those that may lead to death or serious injury. All right? So they're bad enough, we want to tell the patients, we want to tell the physicians they may happen. It has to be cited in all advertising. 66 black box warnings in 2006, 77 new ones in 2007. So if we assume 5 years before the drug disappears off the market, if it's a really bad drug, we're looking at having to have in your head the black box warnings for 350 different drugs, right? Give or take. They also do class warnings. So meaning that it's not just one atypical antipsychotic, it's all of them that can result in diabetes, that have insulin issues, that have higher rates of death. It's the entire group. So if I were a physician and I studied pharmacology full time, I would have all this in my head. But how many doctors can do that? Dear Doctor letters, okay? These are written by the drug companies. They're approved by the FDA. They go out. In order to get access to these letters, you have to sign up for this special healthcare notification network, which also runs drug and device manufacturers. It also has advertisements and a bunch of other things. The website for that, it's new in 2008. It's not clear how many people have signed up. And it tries to limit the amount of information you get because the theory is how much can you actually absorb. So maybe that's a little bit better than it was, but it's still a problem. The next thing we have to find out about drug events is FDA MedWatch. All right? Established in 1993, it's now 16 years later. There's a total of 90,000 people in the entire country signed up for MedWatch. My guess is a third of them are journalists, a third of them work for pharmaceutical manufacturers, and maybe a third are physicians, because it just pushes all this information at you. And its organizational structure is by year of safety alert. All right? So to find out what's going on, you have to look at 6, 7, 10 years of safety alerts to get the information that you need. Am I convincing you all that this is not a system? This is not a system at all. It's a bunch of things that an agency does in response to criticism from various people at various times. So I want to talk about a couple of drugs. First one is a drug called Digitech, which is a generic version of digoxin. All right? Digoxin is used for heart capacity and for arrhythmias in cardiac patients. And there are brand drugs, and then there are generics. And if you ever read the FDA advertisements, they will tell you that the generics are just as good as the brand. They're manufactured with the same tolerances. You can trust these drugs. Well, generally that's true. In the case of Digitech, however, it turned out not to be true. April of 2008, after a series of MedWatch alerts, there was a recall of the Digitech product from the factory sold in New Jersey. From April to September 2008, the FDA received reports of 1,094 patient deaths associated with digoxin through MedWatch. All right? 1,000 deaths reported in 6 months. Now, a MedWatch report doesn't say we know this is the case. It says it's associated with. So it's a weaker causation theory. But 1,000 deaths. Imagine if you had 6 airplane crashes in 6 months. Right? What would the public reaction be? I didn't know about this until I started researching this issue, this set of issues for this presentation. All right. So what we look at is how is a physician to know this? How is a physician to know that this is going on and that the recall has occurred and what patients have it? But here's the reality. This particular generic has a unique NDC number. So who is going to know which patients receive this generic from the pharmacy? Here's a clue. Your doctor has no idea what generic you got, right? Because the decision to give you the generic, if the doctor doesn't check dispense is written on the prescription, the pharmacist gets to pick which generic they're going to use. How do you think they pick it? They pick it on the one with the best price spread between the price they charge the pharmacy and the price that you get to charge the third-party payer. All right? So the pharmacist may know, the doctor doesn't know, but the state knows. Right? The state is able to acquire this information and to run the data for that particular product to find out what patients got. All right? And this leads us to more of, is it inconsistent with sound medical practice? It is. It doesn't mean the doctor's a bad doctor. It doesn't mean they didn't exercise appropriate professional judgment. What it means is that the information to make the judgment and the assessment is available only to groups other than the physician. But it's still not good medical practice. So then we say, when this company figured out that there was a pretty good risk they were killing patients, because what was happening was the medications had, in some cases, the pills in some cases had double the dose they were labeled for. And the problem is, if you want to kill somebody, by the way, this is a good drug to use because it runs through the system pretty quickly. And if you just use it at a high level, you kill them and there's no way to trace it. So we had a nurse in eastern Pennsylvania who used this drug to kill people. He worked on the third shift. He used it to kill people. Not this particular manufacturer, but the generic. All right. So then we say, okay, drug company, you did a so-called voluntary recall when you found out there was a problem. Did you go back and test the drugs to figure out what's going on? What's the answer from my friends at ISM, the Institute for Safe Medication Practices? No, we haven't tested it or not. We have not yet tested it. Why not? Well, we wanted to reach agreement with the 400 personal injury lawyers who filed suit to see how we're going to test it and how we would use the results. So now it's a year after this problem is identified. Nobody's done anything, and the FDA hasn't made them test it. And we now know there are patients out there who got this drug. What happened to them? So it's hard to tell exactly what cardiac patients died from, whether it's this or something else. But the reality is we ought to be able to know and track, and we've got to figure out who has the ability to do that. The next area is atypical antipsychotics. And when I was in my last job, I worked on an investigation of Eli Lilly and their product called Zyprexa. And I'm not going to go into the details of what we learned, except I had to learn a lot of the science in order to put the case together. And so we looked in, so I was familiar with that issue and some of the literature that's come out in the last 2 years, which basically says, do not use atypicals on patients in nursing homes without a prior history of psychosis. Do not. Just don't. There's a Dear Doctor letter from Eli Lilly saying this. There's a black box that FDA put on in August of 2008. And so we ran the data. We ran the data at OMIG, and this was our first project in this area, to figure out what kind of use was being made in nursing homes of this particular drug. And this is where what I call data disaggregation becomes really important. Remember McAllen, Texas, when you disaggregate, they're the most expensive place in the nation for Medicare services generally. In New York, we found there were 2 skilled nursing facilities that had 7 of the top Medicaid prescribers of these atypicals. So now we're not looking at the universe anymore. We're looking at what the FDA says is proper practice. We're looking at what the drug company says is proper practice. And it turns out there's significant outliers. Not a huge number, but the ones that are going to cause the problems are 4 or 5 standard deviations from the median. All right, so we found the 2 skilled nursing facilities with 7 of the top Medicaid prescribers. So what this means is, in the culture of these 2 nursing homes, something is going on beyond individual physician judgment. Right? We don't know whether they all sat around and talked to each other about this is a good way to keep patients under control. We don't know if the nursing home administrator said, if you want to operate in this facility, we need you to write these scripts. We don't know the answer to that yet. So part of the data analysis is the first step to find out what's really going on and how we can address it. This is the black box that the FDA put out. Elderly patients, dementia-related psychosis treated with antipsychotic drugs are increased risk of death. All right, that's a pretty, not hedge, that's a pretty extreme statement for an FDA advisory committee to put out. All right, so now we have a pretty definitive statement from the FDA, but the literature goes back to 2005. Right, and not the New England Journal of Medicine, not exactly around the corner kind of journal. So we ran our data. What did we find? 8,879 New York Medicaid nursing home patients were prescribed atypical antipsychotics. Of those, 3,589 had no prior diagnosis of psychosis. All right. Of the ones with no prior diagnosis, 330 reported diabetes diagnosis after being prescribed an atypical, which is an expected adverse event. All right. So now, out of 4.5 million Medicaid patients, we focused on a very small number who are affected by what's going on. Now we're going to reach out to them and figure out why they're doing it and try to encourage them not to. But part of this is it's a very expensive drug, and the adverse events are very expensive as well. Okay, so that was that initial data mining effort on the drugs. Very helpful. Serves as a roadmap for us for looking at other black box warnings, other MedWatch issues, other Dear Doctor letters, and saying, okay, how did people change their behavior, and what were the consequences after these things came out? But here's the problem with our nursing home patients. After 2006, Medicare covered about 70% of the people in nursing homes in New York are covered by Medicaid. So before 2006, we were paying for all their drugs. After 2006, most of them were covered by Medicaid, Medicare Part D, the drug benefit. So we said, the data we have, the curve peaked 60 to 64, and then it fell off the table. And the reason was being paid for by the people, by the Part D plans, and not by the Medicaid program. So we said, we're not just interested in money, we're interested in what happens to these patients, so let's take a look at the Medicare data. So we reached out to CMS, and we said, we'd like to look at your Medicare, your dual-eligible patients, our dual-eligible patients, to find out what's going on with them. We made a request on April 3rd. They haven't done anything yet about it. But why is that? Why would they? Isn't this an obvious proposition? Isn't this something we'd all like to know? And information that we can use to make a difference. And the response was, well, it's proprietary data. First one was proprietary data for the Part B plans. Excuse me, it's the patient's data, it's the government's money, it's a federal program. Why is it proprietary? Well, okay, then there are privacy issues. All right? So now they said we can't give it to you without going through the privacy board. If you look on the internet, good luck. You will not find the privacy board. It's one of those secret CMS entities that is designed to say, no, we can't do it. So we're going to keep pushing. But there are two things that amaze me here. One is, we had a good idea at OMIG, and the response is, we're not going to do anything. But the second thing is, New York State had the idea, so it can't be rocket science. It's got to be an issue that exists, right, in a whole variety of areas. But now we have two federal agencies. FDA, we don't regulate physicians. CMS, we don't give out data that would tell us what treatments work and what treatments don't, and what side effects and what adverse events people are going to suffer as a result. This is not a system. So when President Obama says we've got to change things, it's not just bad people doing bad things or excessive services. There's a whole series of linkages that you need to run an effective healthcare program, right? And part of that is Inspector General work, and part of that is CMS, and part of it is thinking about it as a system and not just as a series of disconnected activities from which you pay. So then we say, okay, what about the several hundred black box warnings for other FDA-approved drugs? Right? 77 in 1 year. And what you see sometimes is black box, new black box, new black box, drug withdrawn from market. All right, so the black box structure is a pretty good one for predicting which drugs are likely to be withdrawn. So what does CMS do about that? Nothing. Nothing. All right? If you look at their Part D contractors, they have pharmacists who are supposed to look to see pharmacology and the adverse events and so forth. What are they looking for? They're looking for patients who get drug A, which is contraindicated when you get drug B, because all their data is pharmacy data. They know nothing about the patient's diagnosis. So what they're looking for is, if you're already getting aspirin and you shouldn't get acetaminophen at the same time, right? Because the gastric issues and the clotting issues are there. But they have no idea what the underlying condition of the patient is. They're pharmacists. They don't have access to the data. Okay, how about FDA? Right? Why doesn't FDA go to CMS, here's a shocking thought, and say, what can your data for 70 million Americans tell us about what drugs work? Instead of waiting at the phone, hoping some physician will call in on MedWatch and say that I think there's a problem here. Why doesn't FDA go to this repository of data? I don't know the answer to this either. All right. Well, I've asked the question, and there's two houses and they don't talk to each other. And the next piece is, what about us in New York State? And we're working with the Department of Health on this issue. We have the opportunity to be a national leader because our data is so good, because our systems are so good. And of course, when you do this, you can't just stop with the black box and the dear doctor and the tort lawyer's speech about it's a bad thing. You need to make sure we have clinical support and analysis and appropriate literature. So, where does that leave us? I want to do a commercial for OMIG at this point. We still have some more time, but I'll do commercial first. We have a series of model compliance programs that don't address this issue yet, but we will be out in in very short time. We have a series of provider audits that are on our work plan. If you look on our website, if you look at our work plan, you will see the beginnings of this discussion about looking at drugs. And next year I expect to see a lot more. But the idea is, let's not just focus on, how come this person had 3 services in a month and is there a physician's signature on the treatment plan, which is important, but it's not the only thing. Let's figure out what are the big ticket issues that make a huge difference in whether the program works for patients or not. The General Accountability Office, and again, you would think these issues, that is the interaction of drugs, which is about 10 to 15% of our expenditures, and the harm they cause, which, again, if you look at this Horn study, say it's about the same, that total piece is about 30% of the expenditures for Medicare and Medicaid. You would think somebody would be looking at this, right? But the methodologies that are used at the federal level now are, not to say they're designed to ignore, no one talks about them. Because we're still on this model of they're bad guys doing bad things, and we just find out who they are and take their money away, then the system is going to be great. And so they talk about a culture of accountability for improper payments. But again, the focus is not on the medicine. The focus is not on the results. It is on the documentation. All right? And Medicaid, frankly, if you look at documentation, not New York, which is perfect, of course, but in other states, the federal government says there's about $18 billion in improper payments. Now let's go back. Remember our friends at CMS? They've engaged a whole series of contractors to look at Medicare and Medicaid and find out where improper payments are made. But how are they going to do it? They're going to develop and apply algorithms and analyze Medicaid data to select auditees. And my hope is, and I've talked about this, that part of that selection process will look at outcomes and methodologies as opposed to just, there are 2 DRG codes and you have to make sure you use the right one. The auditors are going to go out and do the same thing, right? But they're going to have a set of instructions. And they're going to have educators. My hope is that we can convince CMS on this front to use the same kind of techniques we're talking about at OMID. And they're going to do in New York State 300 audits. But they will be, the question is, those 300 audits, if they are just, where's the paper, are more work that we're already doing. If they focus on outcomes and on these kinds of issues, they can make a huge difference. And I'm going to skip that one. A little bit back, how is it that the New York Medicaid is able to do this and other states are not, right? I said it's not rocket science. Here's what's happened. Bipartisan support over the last 4 years has given us, we've gone from 400 to 600 people working in Medicaid Inspector General's office. A lot of auditors, a lot of investigators, but more and more we have people whose specialty is data analysis and some very fancy tools that we're either have acquired or in the process of acquiring, which allow us to look at these data combinations in real time. One of the things that CMS does that is totally screwed up, in my opinion, is you download the data and then you play with it. All right? So if you have a query that's different from what you started with, you've got to go pick new data, put it in the system, and then wait to see how it goes. And when they're working with the states, they add another layer. You have to, before you get any data from CMS, you have to say, Mother May I, to the Privacy Board or to these Medicaid's, so-called Medicare Medicaid contractors. Same problem. Now we have 2 layers of distance between the data miner and the data. And if you don't know exactly what the question is, the proper question is you're not going to get anywhere. And in my early existence in this process, this is in dealing with Medicare, what we tried to do was to say, we think there's a problem with physicians sending patients to certain kinds of hospitals. We said, so we'd like to break out for every patient with a certain diagnosis at a hospital who the treating physician was, who the admitting physician was. Well, as it turns out, there's a Part A system for hospitals and a Part B system for physicians. So we said, well, give us the data that shows all the patients admitted by Doctors X and all the information about hospital cost and then the other treatments. And we waited 6 months. And this was in the days when data came on those green and white sheets with little things on the edge that you had to pull out. The younger people looking at me like I have 3 heads. But basically they were doorstops, because when you got them, there was no way to figure out what to do with them except to flip through them and find interesting stuff. But usually what you found out was the question that you asked did not produce the answer that you needed to have. So you'd have to go back and start again. And that, to me, is a large part of how CMS is set up. We're trying to get far beyond that. And the data system the Department of Health has, and the new one they're going to put in a year, we think, we hope, is going to make a huge difference on that. And nobody else has it. Other states don't have it. Private insurers don't have it. CMS is working on it, but they don't have it either. So we have in New York a unique opportunity to do this work. But the other people that are thinking about this are the whistleblower lawyers. All right. One of the cases I worked on back in the 90s was a data guy who bought the Medicare data for Pennsylvania for $3,000 from CMS and ran DRG pairs. All right? And what he found out was, in some hospitals, 10% of the patients had strokes, 90% had transient ischemic attacks. All right? In other hospitals in Pennsylvania, 75% of the patients had strokes and 25% had TIAs. And of the 75%, many were discharged. 70% that had strokes, many were discharged in a day or two. Okay, and the Catholic joke here is that was the Lord's Hospital. They had special water that allowed people with strokes to recover in a very short time. But the key was, so again, he was sorting through the data and saying, here's what it tells us. Right? It doesn't tell us that it's a bad hospital. It does tell us there's something anomalous in the way the system is working. Right? How can it be that you're getting 75% of your patients with strokes? And how can it be that they're discharged after 2 days? He ended up getting about $15 million out of that case because he came to us, identified the hospitals, and did some work. But for whistleblower attorneys and for whistleblowers, these data opportunities are huge, and they're walking into our doorstep with this kind of information. And they have an economic incentive that's pretty substantial. Talk about our audit plan, 70 pages of work. Medicaid Fraud Control Unit is doing somewhat similar activities once they have an investigation to see, if you're looking at a nursing home investigation with allegations of abuse, for example, what are the data can we look at to see if that home is the right one to look at. Here's the next piece of things that DOH has done for us. They didn't just do this for us, but they give us information to mine. Present on admission and never events. October 1st, 2008, DOH said to Medicaid hospitals that if you have one of a series of never events, you can't bill us for an increased rate for that service. So, for example, if you cut off the wrong leg and then you have to cut off the right leg as well, you can't bill us for cutting off 2 legs. If you have a patient who develops a bed sore during the time they're in the hospital, you can't bill us for the treatment for that bed sore. And the exception, so that's called a never event. Obviously, they're not complete never events, but they're relatively rare. So what we now know is if we have a list of never events from DOH, and we map that against what's going on in the hospitals in New York, all right? This will surprise you. Again, we're going to have outliers. We're going to have very good outliers. We're going to have very bad outliers in terms of numbers. And we don't have the answer yet. We just know where we should look. Right? Because maybe patients get bed sores because you have a lot more vulnerable population. Maybe they get infections because that's a bug that's prevalent in the area. But it tells you to look at 1% instead of 100% for the same thing. But here's the next great thing about never events. If you want to get paid for never events, you have to code it as present on admission. Right? So the patient showed up. I guess the 2-leg example is not a good one for this. But you have to show up with a bed sore, and it has to be documented that you have a bed sore. Well, now what this does is allow us to map from the present on admission information and find out where do these patients come from, right? If we have 10 nursing homes in your feeder area for a hospital, and one of them seems to have all the patients with bed sores, now we know to look at that issue. If we have patients with septicemia, reporting, that's an unusual one too, but you also get to look at the physicians. So we look at the physician history, the drug history, and the facility history and find out where these patients come from. Now, in the old days, the way we would do this is talk to ambulance drivers, right, who are sort of walking data mining techniques on their own because they go to these places and they see what's happening. But today we can do it by drilling down behind the present on admission information to find out which places we should look at. And we can also track records of individual physicians. What physicians are associated with never events? In the old day, Medicare, you can't do that. In our system, you can. Data mining for patients. Unanticipated deaths in the hospital, skilled nursing facility, and prescription histories. Off-label use and better outcomes. Now, I've talked about the FDA, which approves drugs for one use, but a lot of times, physicians who are in practice realize the drug will work for other things. All right? And there's no law that prohibits this. In fact, very often, on occasion, very often, you find the drug does work for other conditions, and you'll be able to map that with the data. Experimental use and consent. All right? We have drugs that are being tested on these patients. Have they been told what the situation is? third-party liability for treating adverse events, that's a money capture, and capturing adverse events. MedWatch, the assumption is with MedWatch from the FDA, if they get 20% of adverse events, they're doing pretty well. So the 80% out there is the great unknown. And we're going to be able to capture adverse events for the FDA purposes. Hospitals are supposed to report adverse events for devices, right, to the FDA. A lot of them don't. Hospitals are supposed to report to the state of New York when they have an unanticipated death. And they're also supposed to report certain kinds of errors. Well, if you look at Controller Thompson's report from the city, there are hospitals in New York City that do not have a prescription error in the entire year 2007. How likely is that, right? The standard for nursing homes is no more than 5%, which is a whole other issue for another day. But what you look for is, you look for adverse events in the data, and IPRO is already able to do this. That's the contractor that does quality reviews, and map them against what was actually reported. I've talked about unreported adverse events, unreported adverse outcomes. You know, what if you have a death, why did it happen? You can drill down from that. Ranking and rating facilities for an audit focus. One of the things that you find is organizations that are bad at patient care usually are bad at following rules generally. It's just a part of the DNA of that organization. So if you have a bad patient care facility, chances are they're going to have audit issues as well that are dollar issues. Condition of participation failures. Again, when you map a clinic, right, you find out they have bad results. And you look back on the inspection, find out they haven't had utilization review in 3 years. They haven't had a medical director in 2 years. And finally, drug outcomes in populations and in facilities. So there's a drug for smoking cessation, right? Has I think it was the second or third last year in the number of adverse events leading to death or significant injuries. How much of that is communicated in our smoking cessation program? So you want to have a feedback into the process and make sure doctors know what's out there. Okay, and finally the free stuff slide again. If you'd like any of our information, model compliance programs, provider audits for specific providers, you won't find the two issues I talked about on the web yet. We hope to be able to announce a success on our atypical antipsychotic cooperation with CMS sometime in the near future, and we'll put that up. Excluded providers, we see the same people coming back again and again, and disclosure protocol. And with that, I wanted to give you a sense, not yet, but I wanted to give you a sense of the future, which to me is so hopeful. There's so many things we can do that can make a difference, not just in cost, not just in finding bad guys, but in getting better outcomes for the dollars that New Yorkers spend and the federal government spends on health care. So with that, I'm happy to take questions.
Let me go back to one of the first things you mentioned that relates specifically to New York, but perhaps also has relevance to the national discussion as well, and that was the New York Times famous or infamous series of articles on Medicaid waste and fraud and abuse. They used the number of, they said it could be as high as $18 billion a year. And of course, people who are critical of New York's very large Medicaid program like to focus on that, and others disagree. What do you make of that number?
Okay, let me just, the number that they end up quoting in the story, I think, was 10%. I think Newt Gingrich keeps, every time he mentions it, the number keeps going up. So this is one of those urban legend things, trying to find out where did the 10% number come from? And as it turns out, they quoted a gentleman who worked in the OMEG Office of Investigations in New York City. He retired in the year 2000. And they said, you're out on the street every day, what do you think the number is? You're out on the street every day, what do you think the number is? He said, I think it's about 10% outright fraud and 20% abuse, not defined. And if it's true, it's appalling. But then you say, how do you come to that number? What statistical basis you use? How'd you conclude it? I think I wasn't here in 2005, so I don't know what the number was. It was substantially more, I think, than it is now. And we've seen a sea change in healthcare providers and compliance programs in New York in the last 3 years. And we've seen a lot more enforcement and a lot more oversight. And I think an attitudinal change in this administration compared to the previous one about, how important this issue is. And that was not just this administration, it was also the legislature taking the same view. So I think the number is greatly overrated as a fraud issue. But then the question is, what money is there in the system that is being spent for no appreciable benefit? And that's a bigger number than we'd like it to be. And that's why I think the tools we've talked about today are ones that can move us substantially along toward that destination. But the pure fraud, the Albany area has one of the lowest despite being a high-cost area, has one of the lower expenditures in the country for Medicare enrollees, which gives us a sense of what the healthcare community is like. Some of the boroughs are substantially higher, but still nowhere near Miami or McAllen or Los Angeles. So and having lived in both Miami and here, I'm pretty comfortable that the services, the outright frauds that you see in Miami, where they invent the patient, invent the doctor, and invent the device that they're delivering, is much less likely to happen here.
Very good. We do have some time for questions. Let me go to this gentleman over here.
Hi, I'm Andrew Costa with the Home Care Association, and I guess what I was curious about was, in particular, the next phase, what it entails for home care. And having said that, I'll just say, I guess, a couple of things about what our providers have found, which is not you're well aware of, is that a lot of our providers have been audited by the OMIG, and what they've been held responsible for have been certain actions really beyond their control, such as timely physician orders, timely determinations by the local counties and Department of Social Services, timely decisions by the regional resource development centers, really things beyond their control. And I'm just wondering, as you go forward, whether or not you'll be taking any action to help them meet some of these controls, which in the past they've had really no control over.
Okay. This is a fair question. The issue here is, in order to provide home care services, specifically skilled nursing plus, and in some cases personal care services unskilled, you have to have a plan. Remember we talked about the power of the pen and for physicians? A physician has to prescribe the home care services and to approve a plan for what those services are. And the reason we have that as a control is that if I'm the provider who gets to decide what services are necessary, and I'm also the provider who gets to bill for them, then there's a conflict of interest there. We have sat down and talked to several of the home care associations about these issues. If you look at physicians, for example, there is an issue with getting the orders back on time and complete. But the rules are pretty clear that you need a doctor to order these services. The second issue, dealing with the counties. We said, look, where the county is not doing the approval on time, let's walk through what documentation you have to show the efforts you made to get there. And where the agency can show us what the documentation is, they've made the effort, and for whatever reason the county is not being responsive, it seems to me as a government matter that we ought to recognize that in the audits that we do. But we do have a significant problem in New York. If you look, for example, at personal care, down in the city we're doing about 2,000 hours a year. Outside of the southern part of the state, the average hours of personal care are less than a third of that. And so there are significant weaknesses in the program that we're trying to identify. But I agree with you that we need to make an effort to make sure that the people with whom home health agencies deal are getting back to them on a timely basis. And we've talked to the association about ways to do that.
Thank you. Other questions? Let me follow up. You talked about the fact that you talked a lot about the FDA, but other CMS and other federal agencies. If I understood the dates correctly in your slides, you were going back to at least two prior presidential administrations, so this is not a partisan thing. Are you seeing anything concrete yet from the new administration about the need to understand what works, understand what doesn't work, understand and target things that may actually kill people? We've obviously heard a lot of discussion from the president and others. Are you seeing anything concrete yet, or is it too early?
Let's walk through. The president has articulated his belief that you've got to take, if you listen to the speech on Saturday, you've got to take some of the waste and excess out of the system, which I think you quoted this morning. The Secretary of Health and Human Services was approved by the Senate about a month ago. The nominee for CMS was just announced last week. So certainly the policy from the top has been laid down. The question is, how do you implement it? anybody's worked in a bureaucracy where the political appointees are not there yet, you're reluctant as a career government employee to make major initiatives in any area that are different from what existed before because you're waiting for that direction from above. If you come up with the wrong idea, it may not be good for your career health. So there are a lot of people in CMS who are conscious of these issues and sympathetic, but they're waiting for a CMS head to be in place. On the FDA, we have an FDA administrator in place now, but she's like new in the last 3 weeks, I believe. So my guess is it's a very big ship. It's going to take a while to turn it around. And the other piece of this is how does all this play into what you have on national health, the national health reform? It'll be a while.
We'll bring you back a year from now and ask you for your assessment then. Dick?
Thank you. That was a terrific, clear, interesting presentation. And I want to just go back to what Bob was asking, Jim, which is, what about other states? Are there forums for and strategies and tactics for getting states to join together to achieve the kinds of breakthroughs and reforms that you've talked to us about? It's really interesting to hear about.
One of the things that CMS has done that's quite good, in the last 2 years, after the New York Times series on New York Medicaid, Congress passed as part of the Deficit Reduction Act of 2006, said, okay, we want to have more cohesiveness, more organization in the anti-fraud and program integrity efforts. So we're going to give CMS 150 people, we're going to give them some contract money, and we want them to create a Medicaid Integrity Institute. And this facility, it's part of the Department of Justice's Advocacy Center in South Carolina. So many of the people in my agency have never traveled out of state before. What does that tell you? They've been in state service for 20 years. They've never traveled out of state. Some of our New York City people have never traveled to Albany. And you know, when they used Albany, it was almost, it had a certain meaning that was not positive. But what has happened is now these people, some of whom have 20 and 30 years experience and great ideas, are meeting their peers from South Carolina, Florida, Illinois, California, and in this institute, which runs these 3- and 5-day courses. And a number of our people are working as instructors down there. And they go and design the course and teach down there and then come back and work with us. So it's an exciting time to be in this business, because a lot of people have these ideas by themselves, but then they go across the street to the agency or the governor's office, and then it would be shot down. And so now, that never happened. That does not happen in my career here, but before, apparently it did. And so what's happened now is there's a lot of sharing of those ideas and a lot of the processes. The problem for a lot of the states, my counterpart in New Jersey just got appointed in December. And he came in. I came in, there were 400 people working at OMIG. He came in, New Jersey is about a fourth the program that we have. He had 30 people. All right, so getting up in terms of support and skills and knowledge is going to be more difficult for a lot of the other states. But there's a lot out there. We find good ideas from South Carolina, from Idaho. I mean, places that you wouldn't necessarily expect would be in the forefront, because they've been on their own for so long. They've developed a lot of good ideas that we want to steal.
Jane Preston, I think you had a question.
Yeah. Jim, do you
Could I ask you to speak into the microphone?
Do you have any interaction with the Patient Safety Center at the Health Department, and do you expect to exchange the kind of information on outcomes with the Patient Safety Center?
Most of my exchange takes place at the deputy commissioner level. And so we will come and say, this is what we've discovered, we'd like you to take a look at it and see what we can do together, and clinically, is this appropriate, and where can we work with it. But that's a great idea to sort of drill down several levels below.
And they were authorized to come up with best practices and protocols when you're looking at patient care quality.
Good idea.
Noel Hogan, Albany Medical Center. Jim, you described, I think, a great resource to the state, which is this data system, integrated data system. At the same time, you, I think, convincingly argued that it's a very fragmented system, and really that data is only available to us, you, particularly not us. So I guess the question is, I thought I heard you say in there that your hope was that at some point in the future that would be shared, and what I was reading into that was the opportunity maybe for us to get some assistance in our risk assessment or threat identification, and I wonder if you could talk about that.
One of the things that, very good question, one of the things that we try to do in this, we issue every year, this is our second year, we issued a work plan that lays out, if you were a hospital compliance officer, sort of what issues you can expect to be the subjects of audit. Now, it's not a 100% plan because you learn stuff over the year and you redirect. One of the issues that we focused on there was DRG pairs. So, for example, I talked about TIA versus stroke. And if you see if you have a dashboard as a compliance officer and you're seeing the TIA stroke mix in this direction, we tell you that's a pair we're looking at. What I'd like to be able to tell you also is, here's the average for the state, here's the average for hospitals in your area, here are things you can think about patient mix. We're not there yet. But it seems to me if we really expect compliance officers to be within organizations, to be the people who flag issues, which are not intentional issues. They are, what does the data tell us about our organizations compared to others? But we're working on that. It's going to be a work in progress for a while. But I agree with you. I think we want to get that data out to people and tell them what to look for and what to be aware of.